Right. Okay. So good afternoon, everyone. So today, the lecture topic. So this year you have 4 sessions of renal lectures. So one lecture will be on diabetic kidney disease, which will be done by Professor Jayalat, and I think he has probably already done it for you. And he will also do a lecture, maybe combined with the diabetic one, or as a separate lecture on lupus and lupus nephritis. And there will be also a session by Professor Jayalat on infections and the kidney. So I will be doing today's lecture, which will be on kidney and systemic diseases. So this topic is mainly talking about renal manifestation of systemic diseases. And I've selected 4 main areas to discuss today. And you need to note that all these medical conditions will be covered in some place in your medicine lectures. Therefore, I'm only going to touch mainly focusing on the kidney and the renal manifestation of each systemic disease. So what you can probably do is, if you have already finished those lectures, you can add this bit of information into those lectures. So you have one set of lecture notes for them, so that you have a more broader approach to the condition. So of the systemic diseases, the commonly tested areas for you would be lupus, diabetic kidney disease, myeloma, hypertension, liver cell disease, vasculitis. So these are some common areas. And of that, I will be mainly talking about the last 4 sections, and Professor Jayalat will be talking to you on the first 2, the lupus and the diabetic kidney disease. So to start with is myeloma and kidney disease. And just refresh your memory on what myeloma is and how this happens. And I'm sure this was discussed for you in detail in your hematology lectures. So if you can remember the immunoglobulin molecule, I think somebody has their voice on, and could you mute yourself if possible, because I'm hearing a lot of noise from the background. Yeah, okay. So, so in an immunoglobulin, if you look at, you have a heavy chain and a light chain. So you have 2 heavy chains and 2 light chains. And if you talk about the light chains, there are 2 types of light chains, the kappa and the lambda light chains. And you have 5 types of heavy chains, the IgG, A, M, D, and E. If you can remember your immunology. Could whoever who's keeping their the microphone on, can you please mute yourself? Okay, right. So what happens in myeloma is these immunoglobulins, in the plasma cells that produce these immunoglobulins, they proliferate in an abnormal manner, and you have a lot of these immunoglobulins being produced, which is actually what myeloma is. If you take the immunoglobulin molecule, it's not the whole molecule. Sometimes they will produce more of these light chains alone. Sometimes they will produce in excess these heavy chains. Sometimes they will produce the whole molecule, the immunoglobulin molecule in excess. So depending on what is produced, you will have the myeloma. So if it's a kappa chains that they are producing, you call it a kappa light chain myeloma. If it's the lambda chain that they are abnormally producing, you call it lambda chain myeloma. If it's the whole molecule that they are producing, where let's say the heavy chain is IgG and the light chain is kappa, then you call it something like this, IgG kappa myeloma. So that is how the terminology goes for myeloma patients. So if you talk about what happens normally also these light chains are produced by the bone marrow in the plasma cells, around 500 milligrams of these free light chains per day, which is normal. And some of these light chains even normally gets excreted from the glomerulus and is catabolized in the proximal tubule, so that it's only a very small amount in a normal person also that gets excreted. However, if you are having a condition like myeloma, where this number of light chains or the immunoglobulin molecules are produced in excess, then that is when the problem starts. So normally in a normal person, the kappa to lambda ratio is something about 1.8 to 1, or for convenience, you can remember it as 2 to 1. So you have a slightly kappa light chain excess in a normal person also. However, in myeloma, there is much more production of these light chains or heavy chains. And when in excess, this will appear in the urine. And those light chains are what you call as Bence-Jones proteins. So the myeloma is a neoplastic plasma cell disease and commonly seen in the elderly around the age of more than 60 to 70 years. And around 50% of these patients will develop kidney disease because of the myeloma. And a significant proportion, up to about 15% of these patients actually develop kidney disease requiring dialysis as well. And once your kidneys are affected with myeloma, this becomes a significant overall risk factor for the overall outcome for these patients. And this is a picture just to show you how these myelomas can affect at different places. Now, for example, think that this is a myeloma where there is a lot of free light chains being produced from the plasma cells. So they can come into the glomerulus and they can deposit in the glomerulus and the mesangium. And there it will give rise to what is called light chain deposition disease, because the light chains directly deposit in the mesangium. Or else these light chains can produce, can form the amyloid deposition, and you can get amyloidosis of the kidney as well. Further down, if these light chains are going through the filter through the glomerulus, it goes and it can affect the tubules, and you can damage the proximal tubule, and then they will develop a syndrome like Fanconi's syndrome, where they start losing sodium, potassium, calcium, magnesium. So you get a Fanconi syndrome if it affects the proximal tubule. If it goes down this further down into the distal tubule, these light chains can form casts and block the tubules. And there what you get is called cast nephropathy. And some people call this myeloma kidney. That is when you have what is called cast nephropathy. So you can see myeloma can affect the kidney in different ways. Some people will have amyloid, some people might get light chain deposition, some people can have cast nephropathy. So similarly, you can have different manifestations depending on where the kidney is affected. So in myeloma, there are many ways the kidney can affect. So on this axis, on this side, I've written down what I already showed you in the kidney. All of these ways your kidney can get affected with myeloma, and of that, for you, the only important thing would be cast nephropathy and amyloidosis, because those two conditions you need to know. Don't worry about the others. Apart from that, you can have myeloma unrelated renal disease because of myeloma. For example, these myeloma patients will be ill. They will not be taking orally, so they can get dehydrated and they might end up with an acute renal failure. They are immunodeficient because of the myeloma. They can have infection, and infection can cause acute kidney injury. Myeloma will give rise to hypercalcemia as a complication. Hypercalcemia can affect the kidneys. Sometimes these myeloma patients will have back pain, joint pains, bone pains because of the lytic lesion, so they might be taking analgesics. So they can have what is called analgesics nephropathy. So there will be conditions unrelated to the myeloma, but because of the myeloma, the patients will have these complications which will give rise to renal disease. So in myeloma, you say renal disease could be related to the myeloma or unrelated to the myeloma. And clinically, you look always in these patients for the CRAB symptoms. CRAB is hypercalcemia, renal disease, anemia, bone lesions, which are common symptoms you see in multiple myeloma. Apart from that, from a renal point of view, these patients can get a little bit of proteinuria. If they are having amyloidosis, this can lead to a nephrotic syndrome. They can have acute kidney injury. They can have a little bit of hematuria if the glomerulus is damaged. And like I showed you before, if the tubules are damaged, they can have tubular dysfunction like Fanconi syndrome. So it can manifest in different ways. So in the investigations, the routine workup you do, So in any patient suspected of myeloma, the initial investigations will include a full blood count where you look for anemia, you do a ESR, and generally it's very high, most of the time more than 100. And if you do your serum and albumin levels, your globulin levels will be significantly higher compared to the albumin. And this causes a reversal of the ratio of albumin to globulin. And your globulin is high, and that is because the immunoglobulin molecules are in your globulin fraction. So your globulin levels tend to go up. If you do a blood picture and you look for ruler formation there, you do urine Bence-Jones proteins, you do a skeletal cervical to look for lytic lesions, and you do investigations like serum calcium to look for hypercalcemia. This you do in any of our myeloma patients. However, for the confirmation, you need to do serum protein electrophoresis. So this is a normal electrophoresis, and if you can remember your physiology days, you have the albumin, alpha 1, alpha 2, beta, and the gamma regions. So in a myeloma patient, this gamma region is going to increase because of the plasma cells, and you will see a spike like this. But more than that, your immunofixation, and you can directly do the serum free light chain. So you can do a blood test to look at the amount of free light chains in the blood directly, which will be much better than doing the serum protein electrophoresis. However, the definitive diagnosis will be arrived with a bone marrow biopsy. However, if the kidney is affected, you have to do a renal biopsy to see what sort of renal damage has occurred because of the myeloma. So just one word regarding karst nephropathy. So what happens in karst nephropathy is that, so you have the tubules, you have the light chains. These light chains will go down the tubules, and it can block the tubules. These light chains will get entangled in your normal TAM hospital proteins, and then they will cause karsts. And these karsts will go and block the tubules, and you end up with an acute kidney injury because of blockage of the tubules. And that is what you call karst nephropathy with myeloma patients. And this is if you do a renal biopsy, this is how you are going to see a karst. So this is a tubule, and you can see in the middle of this tubule there is a karst that is occluding the whole tubule. The other common way is amyloidosis, which you need to know, and we have already discussed this briefly with one of your MCQs. If you do a renal biopsy, you will see these nodules in the glomerulus, almost like in your diabetic patients, and they will stain positive with the Congo red stain. And this you need to know for your MCQ purposes. And if you look at this glomeruli under a polarized light, you will see this apple green birefringence, this apple green appearance, because of the amyloids that are deposited in the kidney. So in the management, what do we do? The management is mainly hematological. So you need to start chemotherapy for this underlying myeloma. And depending on the patient, there are many therapeutic protocols that they can adopt, and it will be individualized according to the patient's problem and the situation. However, I said there are about 10 to 15% of patients who might actually require dialysis. And there we can use what is called this high cutoff dialysis, where you can use big membranes to remove some of the free light chains from the circulation, which will help in reducing the free light chain load in these patients. So if you know about that much for the myeloma with renal disease, that's more than adequate. So myeloma is something that affects the whole body. It's a systemic illness, but it predominantly affects the kidneys as well. So the next topic I want to touch is hypertension and the kidney. Now you know that hypertension can give rise to kidney disease. So if you have uncontrolled hypertension going on for a long time, that can damage the kidney. At the same time, it can happen the other way also. If you have a kidney problem because of the kidney disease, you can develop hypertension as well. Most of the time, when a patient comes with hypertension as well as kidney problem, it's very difficult to differentiate whether the hypertension came first or the kidney disease came first. So it becomes a bit difficult to differentiate the two, and you need to have your clinical judgment in the management of these patients and in the diagnosis. Now, I'm not going to talk about hypertension because you all have had separate complete lectures on hypertension. I'm just going to touch a little bit about how hypertension can affect the kidney and vice versa. So hypertension, you know, if you talk about the causes, it could be primary or it could be secondary. So primary or essential hypertension, if it goes on for a long time and not controlled well, this can lead to CKD. At the same time, secondary hypertension, there are many causes like your endocrine causes, vascular causes, and renal causes are also one cause of hypertension. And under that, you have renovascular disease like renal artery stenosis. You can have glomerular diseases like we have discussed already, the nephritic syndrome, in conditions like that, which can cause hypertension. And you can have chronic kidney disease, which will also give rise to hypertension. So it can happen both ways. So what happens when you have hypertension? When you have long-term hypertension, with time, this pressure is going to damage the blood vessel lumen, and it's going to start thicken, and the lumen and the endothelium starts proliferating. It will start getting thick, and the lumen diameter is going to get less and less. And you can imagine when the diameter of the lumen gets less, the blood flow to the kidney is going to become less and less, and the kidneys are going to become ischemic. And when this continues to happen for a long time, you end up with fibrosis, sclerosis of the glomeruli and the interstitium, and you end up with chronic kidney disease. In a condition like malignant hypertension, where the blood pressure suddenly goes up or whether suddenly overshoots, the kidneys are not able to auto-regulate this blood pressure. So there is much more damage than a gradual increase in hypertension, and this damage is very rapid. What happens is this pressure directly gets transmitted to the glomeruli and then damages the blood vessels, and you get what is a type of a necrosis called fibrinoid necrosis. So if you look at a picture of that, in the hypertension, what happens is, now this is a blood vessel. You can see layers and layers of endothelium that has gotten proliferated, and you can see the lumen of the blood vessel has gotten smaller. And when this happens, all the places that this blood vessel supplies are going to get ischemic. And if you look at these glomeruli, you can see this urinary space around this glomeruli is a bit larger than in the normal. So this glomeruli has gotten shrunken because it's now ischemic. And if you look at the interstitium of the kidney, there is a lot of fibrosis and sclerosis. And all this is because hypertension has affected the kidneys, and now it has gone into develop CKD. In malignant hypertension, the same changes occur. You can see these multiple layers of endothelium, but at the same time, because the pressure directly gets transmitted without any filtering, you will get a necrosis of these blood vessels and the glomeruli called fibrinoid necrosis. So that is the pathology behind how hypertension can affect the kidneys. So clinical features wise, I mean, you know how hypertension can present and how hypertension can affect almost all body system. It can affect the heart, it will affect the brain, it will affect the nervous system, it affects almost all body systems. Therefore, hypertension, similarly, these patients should be considered as high risk for developing CKD. And if you remember our discussion regarding CKD, CKD is a condition where you have to go looking for it. You have to monitor to identify CKD early. So all your hypertensive patients needs monitoring of their renal function to identify whether these patients are developing CKD early onwards. And if there is a rise in serum creatinine, then very likely this is hypertension related CKD, and you need to really manage these patients very well. In the UFR, generally you have a little bit of proteinuria. You can get some microscopic hematuria in hypertension, and you can develop almost all of the features suggestive of CKD as well. In the management, it's mainly control of blood pressure. In CKD related to hypertension, if you can control the blood pressure very well, most of the time you can actually reduce or even stop the progression of the CKD from advancing into a lower GFR state. So the usual things apply. You have to put them on a low salt diet, stop smoking, regular exercise, active lifestyle. and you need to control the blood pressure very well. So I'm not going to talk about management of hypertension because you've already had this discussed during your hypertension lecture, but the same principles will apply when you are developing CKD secondary to hypertension as well. So when we talk about hypertension and secondary hypertension, renal artery stenosis is one of those conditions which you need to know a little bit about because it gets tested at your exam. So what happens with renal artery stenosis is there is a stenosis of the renal artery which will result in reduction in the renal blood flow distal to it. And you know from your physiology that when the renal blood flow goes down, there will be a stimulation for renin to increase, and renin will stimulate angiotensin 2, and the whole cascade of this activation starts working, and then your blood pressure will go up, and that will also affect your kidney function, and so on and so forth. So that is why in renal artery stenosis, patients have poorly controlled or very high blood pressures. When you talk about causes of renal artery stenosis, there are many causes, but the commonest cause is because of atherosclerosis, where you get an atherosclerotic plaque which deposits in the renal arteries. And out of all the renal artery stenosis patients, 70 to 80% of the renal artery stenosis is because of atherosclerotic lesions. The next group of causes is what you call fibromuscular dysplasia, and this accounts to about 10 to 20% of the patients, where there is some abnormal fibrous growth that happens in the arterial wall. Apart from that, vasculitic conditions like in Takayasu syndrome, neurofibromatosis, trauma, radiation, all this can give rise to renal artery stenosis. But for you, it's very important that you at least know the first two conditions of atherosclerosis and fibromuscular dysplasia. So the atherosclerosis is more seen among males than women, and typically in the elderly, when your age is about 40, 50, that's when you start seeing renal artery stenosis in an elderly group of patients. And if it is secondary to atherosclerosis, generally it's the proximal part of the renal artery that's mostly affected. And most of these patients will have other complications secondary to atherosclerosis like peripheral vascular disease, ischemic heart disease, strokes. So you will see it affecting other body systems as well. However, fibromuscular dysplasia is a completely different entity where you commonly see it among females who are young, around 40, 50. That's the time you start seeing fibromuscular dysplasia. And generally that affects the mid to distal part of the renal artery. And if you do an angiogram, they have this characteristic appearance called string of pearls appearance. And you can see here, this is the renal artery, and you can see this appearance which is called a string of pearls, like multiple pearls. So those are multiple aneurysmal segments that you see, which is typical of fibromuscular dysplasia. So clinically, how do these patients with renal artery stenosis present? These patients will have refractory hypertension. On examination, if you auscultate for renal bruit, you can hear a renal bruit. And you might have other complications like rapidly declining renal functions, or these patients will say that they've had repeated episodes of flash pulmonary edema. Those are the common presentations of renal artery stenosis. And if you want to diagnose renal artery stenosis, you initially do an ultrasound scan with a duplex renal artery scan. And in the ultrasound scan, the site that has the renal artery stenosis, that kidney will be proportionately smaller compared to the normal sized kidney. And normally when that discrepancy is about more than 1.5 centimeters, you have to be very suspicious whether there could be a renal artery stenosis. And when you do a duplex renal artery, now here this is a duplex scan, you can see a stenotic, a narrowed segment. You sometimes can see a narrow segment in the duplex as well. However, the gold standard would be to do renal angiography with either CT or MRI. So if you do a CT or an MRI, here you can see with the angiogram. So this is your aorta, this is our renal artery, and this segment that is narrowed. As opposed to this side, it's nicely there, it's a normal side. This is a MR angiogram, and you can see bilateral renal artery stenosis. You have the aorta, renal artery, and then you have a narrowed segment. So this is how you diagnose renal artery stenosis. So how do you manage these patients? So blood pressure control becomes very, very important. So you have to control the blood pressure very well. If the underlying etiology is atherosclerotic, you might have to start thinking of giving statins and aspirin. And sometimes if these patients develop complications, which I have mentioned here, the indications, if they develop complications like flash pulmonary edema, or if they only have one functioning kidney and if that side renal artery is stenosed, or if their kidney function is declining very rapidly because of the renal stenosis, that is the time you think of revascularization using angioplasty or stenting for these patients. So, and that is how you are going to manage a patient with renal artery stenosis. Okay, so before I move on to the next two topics, any questions based on those two discussions regarding hypertension, CKD, or regarding myeloma? Any questions anyone wants to ask?
Excuse me, sir.
Yeah.
So I have a question about renal artery stenosis.
Yes.
So if we are going to control the blood pressure, does it worsen the condition of the kidney?
Okay, so good question. Now blood pressure control means now if let's say a patient is having a blood pressure of 200 by 100. Now, more than the kidney, all the other body systems are going to get affected with that blood pressure as well. So you need to get that blood pressure down to a reasonable level where it's not going to affect the other systems, as well as it will maintain the perfusion to the kidney. So most of the time, if you get this gradually down without a sudden drop, the kidney will adapt to that and kidney will manage to have adequate perfusion. However, there are certain medications that you need to be cautious of, especially your ACE inhibitors and your angiotensin receptor blockers, because those can actually worsen or lower the renal perfusion further. Because you can understand, the kidney is already having a low afferent arterial blood flow coming in. And if you are going to give ACE inhibitor or an angiotensin receptor blocker, that's going to further efferent arterial vasodilate and it will further reduce the GFR. So the perfusion to the kidney is going to become even lower. So you should avoid your ACE inhibitors and angiotensin receptor blockers in the control of blood pressure and use the other drugs, and that will not affect the blood flow to the kidney that much. Any other questions? Okay, so we'll move on to the next area, which is your hepatorenal syndrome. Now, I'm not going to discuss chronic liver cell disease here. That has been done as a separate lecture for you. Here, I'm going to talk about when you have a cirrhosis or a chronic liver problem, how that can affect the kidney. And when that happens, you call it hepatorenal syndrome. So this is a condition where there is deterioration of renal function in a patient with acute or chronic liver disease. So it can happen in acute situations as well. And what is important is this is a diagnosis of exclusion. So just because a patient with cirrhosis or liver cell disease has a kidney problem, you can't straight away say that this is hepatorenal syndrome. There are so many other conditions that can give rise to renal problems in liver cell disease patients. You need to exclude all of that before you come to a conclusion that this is hepatorenal syndrome. Generally, this represents the last stage of a sequence of reduction in renal perfusion due to increasing hepatic injury. So what happens when your liver cell disease progresses gradually, the blood flow to the kidney goes down, and we will discuss why that happens. And you start developing acute kidney injury during the very late stages, because by that time the kidneys has tried to compensate and now has starting to fail. Commonly, you see hepatorenal syndrome happening in patients who develop significant portal hypertension due to cirrhosis. In patients with severe alcoholic cirrhosis, you see this. Significant metastatic tumors and fulminant hepatic failure. So you will generally not see hepatorenal failure in patients with child A, child B grade. So early liver cell disease patients, you will not see this. You generally see when it's very, very advanced. So what happens pathologically? So these patients with cirrhosis develop portal hypertension, and that will result in splanchnic vasodilatation because of multiple mediators, your nitric oxide and things like that. And when your splanchnic vasodilates, there is a lot of blood pooling there, and the effective circulatory volume goes down, and the perfusion to the kidney starts going down. And when the kidney's perfusion goes down, with time that will stimulate the renin-angiotensin-aldosterone system. And with time, there will be more and more renal vasoconstriction, more and more sort of a pre-renal sort of a acute kidney injury developing. And that is what you call hepatorenal syndrome. So hepatorenal syndrome is by definition a pre-renal sort of an acute kidney injury because of the reduced perfusion to the kidney. In the clinical features, this is a renal dysfunction in patients with liver cell disease as we discussed. These patients have progressive rise in creatinine. However, what is very important is when you do a urine full report, the urine sediment will be bland. That is, there should not be any significant red cells. And sometimes you can have a little bit of protein, but you should not be having an active urinary sediment. And because this is a pre-renal sort of an acute kidney injury, and if you remember from your acute kidney injury lecture, if it's pre-renal, you may remember that your urinary sodium levels will be low. So if you do a urinary sodium level, that will be low. And because it's a pre-renal failure, the patients will be oliguric. The diagnosis is by exclusion, as I mentioned. So to the main criteria that you need to have is you need to have advanced hepatic disease and portal hypertension. You need to demonstrate there is an acute kidney injury, and you need to demonstrate that there is no other cause that can be attributable to this acute kidney injury. Note to make regarding kidney function in patients with liver cell disease, there are problems when doing creatinine and urea in patients with liver cell disease. Normally, the production of creatinine and urea is reduced when your liver is not functioning well. And also when these patients are ill with chronic liver cell disease, they don't take orally, their muscle mass is low. So there is not much of a generation of creatinine, so your creatinine will be abnormally low as well. So creatinine might not be a very good marker in these patients with chronic liver cell disease to assess kidney function. At the same time, nowadays, of course, we don't use this method, but those days we used to use this Jaffe reaction to check the creatinine. And in liver cell disease patients, when your bilirubin levels are high, this can actually interact with the Jaffe reaction and can cause interferences with the creatinine estimation. So these are some of the limitations in assessing kidney function in a patient with chronic liver cell disease, which you need to be aware when interpreting the reports. So what precipitates a person to develop hepatorenal syndrome? So there might be a patient with chronic liver cell disease who's compensating nicely, but a bacterial infection or a GI bleed or any infection such as bacterial peritonitis, or if you give something like a nephrotoxic like NSAIDs, if you give diuretics to reduce the edema, and if you dehydrate the patient, these are some situations where even a previously stable chronic liver cell disease patients can decompensate and could precipitate hepatorenal syndrome. So you need to try and avoid these situations in these patients. And when you talk about hepatorenal syndrome, there are two types that are described, type 1 and type 2. Type 1 is where your kidney function rapidly declines, usually within 1 to 2 weeks. And the overall prognosis is much poor in this group of patients whose kidney function declines very rapidly. Type 2 is where the kidney function decline is very slow to happen. It happens over a period of time. And usually this happens with chronic cirrhosis patients with portal hypertension. And these patients tend to have refractory ascites as well. And the prognosis is a bit better than your type 1 hepatorenal syndrome patients. However, if you look at the overall prognosis, if you develop type 1, your median survival on average is very short, up to about 1 to 2 weeks. Type 2 hepatorenal syndrome, your median survival is around 6 months. So they don't really have a very good prognosis overall. And like I said, this is a diagnosis of exclusion. So like in any patient who presents with a kidney injury with increased creatinine, you have to think of all the other causes before you come to a diagnosis of hepatorenal. So you have to think about glomerular diseases, acute tubular necrosis, other pre-renal causes. And generally we don't need to do a biopsy in these patients. And also it's very risky to do a biopsy in liver cell disease patients because of the coagulopathy and thrombocytopenia. The bleeding risk is also very high. So we try to avoid kidney biopsies as much as possible. So more than treating hepatorenal syndrome, our focus should be to prevent hepatorenal syndrome developing. So we spoke about the precipitating factors. So we need to try and detect those precipitants very, very early and try to avoid those escalating into hepatorenal syndrome. And especially in the management of ascites, it needs to be a stepwise ascites management and try to avoid excessive diuresis in these patients. So initially you would advocate a low salt diet. You can add a diuretic like spironolactone and gradually increase the dose. Furosemide also, rather than starting with very high doses, you can gradually introduce it. If there is ascites, you can do therapeutic paracentesis while giving albumin, because if you remove a large amount of paracentesis fluid, that will also precipitate an acute kidney injury. In these patients, you need to avoid nephrotoxics and use beta blockers very cautiously. So this is in order to avoid patients developing hepatorenal syndrome. However, once a patient develops hepatorenal syndrome, the overall prognosis is very poor. And unless these patients are potentially transplant patients, or unless you think this might recover, there is very little we can do to improve the overall situation. So pharmacotherapy-wise, we give albumin to increase the circulation so that the colloid osmotic pressure increases with albumin and there will be more circulating volume. You need to start drugs like terlipressin, noradrenaline, or vasopressin. So terlipressin is the drug of choice at this point that will vasoconstrict your splanchnic circulation and increase the perfusion to the kidney, thereby reducing the pre-renal element of the AKI. Very rarely you can do TIPS. Sometimes there is, like in your dialysis, there is extracorporeal liver support. Renal replacement therapy you do only if these patients are potentially waiting for liver transplant, or if you feel that these patients' liver functions are going to improve if you support with dialysis. Otherwise, generally for most of these patients, dialysis is not going to provide any benefit or help in the recovery of this process. However, liver transplantation becomes the best mode of therapy, and most of these patients should be going for liver transplantation in order to improve the hepatorenal syndrome. And that's all about hepatorenal syndrome. So if you know that hepatorenal syndrome happens in liver cell disease patients, that there are two types, prognosis is poor. And if you have a little bit of an understanding about how hepatorenal syndrome occurs, and little bit about knowing a little bit about the importance of albumin, terlipressin, that's more than adequate for you to know about hepatorenal syndrome. So the final topic is vasculitis. Before I go into vasculitis, are there any questions you want to ask? Okay, right. Now, vasculitis, this is a topic which already would have been taught to you during your rheumatology lectures. So I'm not going to go into the topics, and here again, I'm going to limit myself to how vasculitis conditions will affect the kidneys. And when we talk about vasculitis, it's a very non-specific term which indicates diseases of the blood vessel where the blood vessel wall becomes inflamed. And you can imagine blood vessels, because it's throughout the body, if you have a vasculitis, it can affect any organ system. And most of the time, this small vessel vasculitis is the one that causes the most amount of damage to multiple organs. So when do you suspect a patient to have vasculitis? If a person comes with a multi-system involvement like skin, renal, respiratory, neuro, if there are multiple body systems affected, you always think of the possibility of an underlying vasculitis. If there are unexplained symptoms, if a person has unexplained symptoms, high ESR, you think of the possibility of an underlying vasculitis. If patients have vasculitic type of rashes, skin purpuric rashes, you think of possibility of vasculitis. And in the classification of vasculitis, you need to know this classification broadly. You divide it according to the size of the blood vessel, according to small vessel, medium vessel, and large vessel vasculitis. Now, the large vessel vasculitis, Takayasu's giant cell arteritis, you already have separate lectures. Medium vessel vasculitis also is separately told. But the commonly what affects the kidneys are your small vessel vasculitis, where you divide it broadly into ANCA-associated vasculitis and immune complex mediated vasculitis. And in that, I'm going to only discuss in brief about this ANCA-associated vasculitis conditions, because that is the one that commonly affects the kidneys. So what happens in this ANCA-associated vasculitis is, it's a small vessel vasculitis. Around 80 to 90% of this vasculitis affects the kidneys. And this can happen at any age, but you commonly see this in the elderly group of patients when they are more than 56 years of age. So what happens is, this is a blood vessel, this is the endothelium, you have neutrophils circulating, the body produces antibodies against some of the components in these neutrophils. And that is why these antibodies are called anti-neutrophil cytoplasmic autoantibodies, ANCA. And once they go and bind to the neutrophils and starts damaging or binding to the neutrophils, these neutrophils get activated and they go and damage the capillary endothelium or the blood vessel endothelium. And that is why ANCA antibodies can cause a vasculitis throughout the body. And that is what basically happens. And when you talk about these ANCAs, we talk about mainly two patterns, C ANCA and P ANCA. C stands for cytoplasmic ANCA, P stands for perinuclear ANCA, and that is dependent on how it stains when you put an immunofluorescence. So you can see in this picture, so this is a neutrophil, this is the neutrophil, the nucleus, and this is the cytoplasm around the nucleus. And you can see immunofluorescence is staining around the neutrophil in the cytoplasm only. And that is why it's called a cytoplasm C ANCA, because it stains like that. If you take the perinuclear one, here you can see it's staining around the nucleus. There you say it's perinuclear ANCA. The antibody, the antigen here is what is called a proteinase 3 antigen. In P ANCA, the antigen is myeloperoxidase. So you develop this ANCA against this proteinase 3 antigen in the neutrophil. Therefore, you call them PR3 antibodies. In P ANCA, you call them, because the antigen is myeloperoxidase, the antibody is MPO antibodies. So these PR3 antibodies or the C ANCA pattern you see commonly with your vaginous granulomatosis. The P ANCA pattern or the MPO antibodies you see with the microscopic polyangiitis or your Church-Strauss. So if you go through your textbook, the Kumar and Clark or your Davidson's, you will come across these terms like C ANCA and PR3 MPO antibodies. That is what it means. So clinically, depending on the condition, you have other system involvements, but in the kidneys, they will commonly present as an AKI or a rapidly progressive glomerulonephritis. So that is the classical pattern these ANCA-associated vasculitis presents. They will have hematuria and they can have proteinuria as well. And you can remember this slide from my lecture on acute kidney injury and glomerular diseases, where we discussed RPGN. There are 3 categories of causes, and of that, one category is your post-immune GN, that is your ANCA-associated vasculitis. So that is where all these conditions fall into in RPGN. So this is just a summary slide for your convenience. So the main three conditions with ANCA-associated vasculitis is your vaginous granulomatosis. Nowadays we call it granulomatosis with polyangiitis. Other one is Churg-Strauss. Nowadays we call it eosinophilic granulomatosis with polyangiitis, and your microscopic polyangiitis. So clinically, the vaginous granulomatosis, you have respiratory involvement predominantly, where it can affect the upper respiratory tract as well as the lower respiratory tract, and you will have renal involvement. And when you do the investigations, the C-ANCA is positive in more than 90% of these patients. And if you do biopsies, you will have granulomas seeing, and that's why it's called granulomatosis with polyangiitis. In Churg-Strauss syndrome, the classic features, you have asthma-like symptoms, allergic rhinitis. It can affect most of the organ systems, including the renal. However, in investigations, they are predominantly having P-ANCA, and in the full blood count, they will have an eosinophilia, and they will also have granulomatous lesions. The microscopic polyangiitis, there you will see a lot of neurological involvement with lung involvement. There you can see both P as well as C-ANCA antibodies, but P is more common than your C-ANCAs. So this is a few ways you can differentiate each of these conditions. So when you are suspecting a vasculitis, these are the common renal specific investigations you have to send. You have to do the renal functions, the UFR, urine PCR, the inflammatory markers, complement levels, the ANCA antibodies. Then you have renal biopsy is a must in these patients, and depending on the organs involved, you have to do those specific investigations. And if you do a renal biopsy, these patients will have what is called crescentric glomerulonephritis, and if you do immunofluorescence, they will be pauci-immune. That means the immunofluorescence will not stain them. So you can see there is no staining at all here, and that is called pauci-immune staining of immunofluorescence. So that is the typical lesion you will get with the ANCA-associated vasculitis. In the treatment, you don't need to know in detail about these, but in the induction phase, or that is the initial phase of treatment, depending on the underlying condition, you can use drugs like methylprednisolone, cyclophosphamide, rituximab, or even sometimes plasma exchanges. And once the initial period is over, these patients need to be maintained on low-dose prednisolone and azathioprine or drugs like methotrexate. And that is how you treat conditions like ANCA-associated vasculitis with renal involvement. Right. So thank you very much for listening. So with that, I'm going to stop there. So what I've done is I've tried to discuss 4 conditions which affects the whole body, can affect multiple systems, and I've tried to focus on the kidney and see how these conditions affects the kidneys. And why I've chosen them is because once the kidney gets affected with any of these conditions, then the whole management is dependent on how the kidney functions rather than anything else. So that is why I've chosen these 4 conditions to mainly talk about. Apart from this, your diabetes, your SLE are 2 very, very important conditions that you need to know of. Right. So any questions you want to ask? Okay, so I'll just have a look at the chat area, but before that, so next week, the lecture topic will be cystic renal disease. That is where I will discuss a little bit about polycystic kidney disease, and your tubulointerstitial diseases, that is your acute interstitial nephritis, chronic interstitial nephritis, that group of conditions I will discuss next week. Now your schedule would have said glomerular diseases, nephrotic and nephritic. I think that's by mistake because we have already done that lecture in your 4th year and we've already had a few conversations around the MCQs and the case discussions. So next week, this will be your topic for me to discuss. Right. So in the chat area, are there any questions. Okay, so one question is, how can we differentiate vaginous granulomatosis with Goodpasture syndrome by history? So it's sometimes difficult. Goodpasture syndrome is something different to your vasculitis. Goodpasture syndrome happens because of anti-glomerular basement membrane antibodies. So they are the typical history most people would give is it will be a male patient in their young, 40s, who's a smoker. So generally, there's people who smoke are at a high risk of developing Goodpasture syndrome. And you will have lung and renal manifestations. Goodpasture doesn't generally affect other systems. It's mainly the lung and the kidneys. And the lung manifestation is mainly with regards to pulmonary hemorrhages. So that is a few pointers to say whether it's Goodpasture or not. But the best way to differentiate is by doing a biopsy, where with Goodpasture syndrome, if you stain with immunofluorescence, you will have a linear IgG pattern that you can see in with Goodpasture syndrome. So that is how you can separate that. Yeah, so that's the only question. Yeah, the few